All right, welcome to Decoding DX 10 Clinical Minutes. It's Wednesday, September 2nd, 5:30 in the morning. It's a beautiful morning. Thank you all for joining us. Today we've got an awesome presentation from Kelsey talking about ABGs. So with that, I'll hand it over.
All right, can you guys hear me okay? All right, so I wanted to kind of start by saying my goal with this presentation was to give everyone essentially a clinical framework for interpreting ABGs. So I'm not necessarily going to go into kind of the basic sciencey aspects of it. More so, I'm going to breeze through a framework that you can use and then show a couple examples of how to use this framework kind of in the future as a way of interpreting ABGs. So quick normals, pH around 7.4, PCO2 around 40, and bicarb around 24. As a general rule, you want to use the value from the CMP for the bicarb, and then use the pH and PCO2 from the ABG itself. So if you have both of those labs, that's kind of how you want to choose those. So step one is just looking at the pH and determining overall, is the blood acidemic or alkalemic? So pH less than 7.35 acidemic, greater than 7.45 alkalemic. And then step two, you're going to look at the pH and PCO2 to determine whether the primary acidemia or alkalemia is metabolic or respiratory in nature. And so if the pH and PCO2 are going in the same direction, it's going to be a metabolic. And if they're going in opposite directions, it's going to be respiratory. And so here's kind of just examples of that. Same direction are both metabolic. Opposite directions are both going to be respiratory. And then the next step will be you're going to look at the expected compensation. So for metabolic acidosis or alkaloses, you're going to calculate the expected PCO2. And for respiratory, you'll calculate the expected bicarb because that's kind of how the compensation works. So you'll calculate the expected value for either of those. And that will tell you, is compensation appropriate? And therefore, there are no further acid-base derangements, or is there an additional disturbance going on? Hope you have a guess. Is there an additional disturbance going on if it's kind of the values even further outside that range? So here are the equations for that. And I won't get into those right now, but that's when you get into like the Winter's formula and things like that. And then kind of next step, you always want to calculate an anion gap, which can be calculated with sodium minus bicarb minus chloride. If it's greater than 12, there's a gap present. And as a side note, you can have a normal pH if it's a mixed acid-base disorder. And so the anion gap can be the thing that tips you off to that. And so even if the pH is completely normal, you always still want to run an anion gap just to know. And then step 5 is specifically for if you have a metabolic acidosis. You'll want to calculate the expected bicarb, and that will help you look for an additional metabolic disturbance on top of the metabolic acidosis. And so if it's a high gap or a normal gap, there's two different equations that you'll use. And then just as a couple of, and we'll kind of get back to a couple of these, but here's just a list of the different causes. But as a general rule, if it's a metabolic disturbance, you either have lost an acid or you've gained more of a base. Or vice versa. And so it's basically just derangements of that versus respiratory disturbances are basically you're breathing too much or too little. So hypo or hyperventilation are going to be all your causes of your respiratory acidoses and alkaloses. So here's kind of an example that we can go through for this first one. So for this example, it's a 42-year-old man with a blood pressure of 172/98, sodium of 151, and a K of 3.1. So pH is 7.5, PCO2 of 43, and bicarb of 30. So does anyone want to kind of say, so for number one, pH, are we acidemic or alkalemic?
Looks pretty alkalemic to me.
Yep. So we're alkalemic, and then pH and PCO2 go in the same direction. So which one will that make this?
Looks like a metabolic alkalosis.
Yep, exactly. So same direction, it's going to be metabolic, so therefore it's a metabolic alkalosis. So we're going to calculate the expected PCO2 in order to see if there's any further disturbances or not. And so in this example, the observed increase in bicarb is what we need to look at. So bicarb is normally 24, our bicarb is 30. So the observed increase in bicarb is 6. So you'll do 6 times 0.6, which is 3.6. So you would expect your PCO2 to increase by 3.6 with a range of plus minus 2 on either side. So our expected PCO2 will be 40, which is normal, plus 40, the 3.6. So expected PCO2 is 43.6, with this being the range of plus or minus 2 on either side. And so our actual observed PCO2 is 43, which is in the expected range. So the compensation is appropriate, and there's no further metabolic or respiratory disturbances going on. In this case, it would tell us about respiratory. So there's no further issues going on. I didn't give lights, so we can't calculate the gap on this particular one. But so for metabolic alkaloses, we have an addition of a base or loss of acid. So here's some examples: antacid use, hyperaldosterone, dehydration, volume down, loop diuretics, vomiting, or NG suction. Does anyone want to guess which of these causes this guy had?
I can just keep the train going unless anyone else wants to jump in.
If you can hear me, I'm going to guess loop diuretic use or vomiting.
So for this guy, it's actually hyperaldosterone. So with that high blood pressure, elevated sodium, and low potassium. And so metabolic alkalosis, due to hyperaldosteronism, you have a renal hydrogen ion loss. And so that's what causes the loss of acid kind of type. So next step for this, just as a clinical kind of pearl, next step is to look at renin aldosterone levels, because if you have a primary adrenal cause where you're just hypersecreting aldosterone, you'll have high aldosterone but low renin. In that case, you would want to get an adrenal CT scan. You can also have hyperaldosterone secondary to RAS activation, so like a CHF or liver cirrhosis. So in that case, both aldosterone and renin would be high. And then for treatment, you can give an aldosterone antagonist like spironolactone and identify and treat whichever the kind of cause as above is. So, and then our other example that we have is a pH of 7.31, a PCO2 of 10, and a bicarb of 5. And the kind of clinical correlate is we have a lethargic 87-year-old nursing home resident with a cough and diarrhea. So we'll kind of run through the first few things. So our pH is low, so we're going to be acidemic. And then if we look at the pH and the PCO2, they're both decreased, so they're going in the same direction. Therefore, it's a metabolic acidosis. So we'll follow this pathway. And so we'll calculate our expected PCO2. So that's going to be 1.5 times our observed bicarb, which was 5. So it's going to be 7.5 plus 8 plus or minus 2 as our range. And so our expected PCO2 is going to be 15.5 with a range of 13.5 to 17.5. But our observed PCO2 is 10, which is too low. It's lower than our expected range. Therefore, we have an additional respiratory alkalosis going on. So we know we have the metabolic acidosis, the respiratory alkalosis. We need to figure out if the metabolic acidosis is a high gap or normal gap acidosis. And so here's our lights for that: sodium of 123, chloride of 99. So we can calculate our anion gap, sodium minus bicarb minus chloride, which is 19 for this case. So there is a high anion gap present. And so going over to number 5, because we had a metabolic acidosis, we'll calculate the expected bicarb in order to look for an additional metabolic disturbance. And so we'll use this high gap equation, which is the delta gap. There's the delta gap shortcut that I know Dr. Rouse liked to teach. And so for that, we can calculate the expected bicarb as anion gap plus bicarb minus 12. So in this patient's case, the anion gap we calculated was 19. Plus the bicarb observed, which was 5, minus 12, which is essentially just the expected anion gap. And we end up with the calculation is 12. And the normal range we would have expected is 22 to 30, but this patient had less than 22. And so this patient has an additional metabolic acidosis going on. And so kind of to sum all of that up, a metabolic acidosis that is like a high anion gap metabolic acidosis, an additional respiratory alkalosis, and an additional metabolic acidosis for this patient. So they have several things going on. And that's just to kind of summarize what I just said. And so here are the causes of those different things. We have one of each of these. And so there's kind of a couple things that it could be, but for final diagnosis, does anyone want to take a stab at it? It's kind of, there's probably a couple things it could be, but one in particular that I just kind of chose for this diagnosis.
To me, it looks like this patient's probably pretty sick with possible sepsis, maybe a DKA picture, and some sort of other GI fluid loss.
Yeah, so there's a couple different things that it could definitely be. And another one I thought of was it could be like they took too many medications on accident, or maybe as an overdose or something. So there could be like a toxicity from aspirin, both late and early, and then spironolactone or something like that. What this particular patient had was Legionella septic shock. And so they had the pneumonia and diarrhea from the Legionella plus hyponatremia. And then the lactic acidosis from the septic shock was the cause of high gap acidosis. Great. And then our final slide per request by Ben, wanted to quickly cover how you can convert between ABGs and VBGs. So as kind of a general rule, easy way to think about it is that venous blood gases are going to be more acidotic because they've passed through tissues that are metabolically active, and there are acidotic byproducts from that. So once you get kind of to the venous side of things, it's generally just a little more acidotic. And so the pH for a VBG would be 7.35 to 7.38. Whereas ABG 7.38 to 7.42 is kind of the more normal range. And so it's 3-ish points lower, more acidotic on VBGs as a general rule. It's kind of like your 0.3 to 0.5 lower. And then PCO2s are a little bit higher, which again makes sense, more on the acidotic side, and you've collected PCO2 as metabolic byproducts. So 44 to 48 is generally what you see for VBGs. And then oxygen sat significantly lower, obviously, because oxygen's been used. So the PCO2 is more like 40. And then for bicarb, 21 to 22 on a VBG versus 24 on an ABG, which again makes sense, more on the acidotic side. So it's kind of, as a quick rule, easy to just think, oh, it's more acidotic, and we'll drop a couple points. But here are the numerical conversions for reference. So that is all I have.
Wow, thanks, Kelsey. That was awesome. I definitely encourage everyone to go back and watch that slowly and pause it intermittently to try and work through the math yourself. Working through the math for the acid-base disturbances is definitely a way to look like a complete rock star on rounds. Very few people go into medicine because they like math, as a little disclaimer. So if you take the time to do that, you will definitely look like a rock star, and you can make a real difference in your patient's care. So I definitely encourage you to go back through that, and then also to look for other resources, see what makes sense to you. There's different equations, different ways to think about it. What makes sense to you, learn it, make it stick, use it. It'll be great. So with that, any last comments from anyone? Oh, good appearance from the cat.
Spaced repetition, calculate a gap on every patient.
Always do the gap, as we saw with our last Decoding DX. My fault there. Always do the gap. All right, guys. Have a great Wednesday.